Okay, guys, welcome back. This is client safety. So let's jump right in and talk about what we can do to keep our clients safe and what kind of risks they are facing. So client safety includes falls, fall prevention, seizures, seizure prevention or seizure precautions, and fire safety. So, what is safety? So safety means freedom from injury, and that's our responsibility as nurses to make sure that the clients are safe and we prevent any injuries that are preventable. And there are lots of factors that affect a client's ability to protect him or herself, things like their age. Remember, the very young, the very old are always at the greatest risk. How much mobility do they have? Are they independent with ambulation or do they need assistance? Do they have any cognitive or sensory issues? In other words, do they have any dementia? Do they have visual or hearing deficits? What's their emotional state? Because that affects your safety as well. Are they able to communicate? And do they basically have an understanding of their lifestyle and safety awareness as it relates to their lifestyle? So as nurses, we are responsible to assess these patients, report any things that are pertinent, document their allergies, right? And make sure that we're keeping them as safe as we possibly can. Okay. So there are lots of standardized tools, and you're learning that we as nurses, well, healthcare in general, love standardized tools, right? Because it makes it easy for us to communicate amongst ourselves with regard to the status of a patient. Okay. So we want to use those tools whenever possible. We always want our clients to take an active role in their healthcare, right? We want them, if they're able, to be an active participant. That's the nursing ethical value of autonomy, right? We want to create a culture of checks and balances so that even when things are stressful, like if the facility is jumping and busy, we still want to make sure that we're avoiding errors so we keep our patients safe. And we always want to communicate risk factors and the plan of care. Even long-term care facilities have care plan conferences so we communicate with the family and the other staff members. And communication is super important. All right, let's start with fire safety. So fires can happen in health facilities. Sometimes it's a problem with electrical or, anesthetic equipment or from smoking. So you should know, where are the fire exits? Where are the fire alarms, fire extinguishers, shut-off valves for oxygen? Making sure that if there are fire doors, they're not blocked, right? And knowing whatever your evacuation plan is, right, for your facility that you work in. That's super important, okay? Everyone needs to know RACE, all right? And as a matter of fact, let me highlight all of this because you need to know RACE. RACE is an acronym, and by now we love acronyms, okay? What it means is rescue, alarm, contain, and extinguish. Pretty much every healthcare facility that I'm aware of uses RACE, in other words, in how to respond if there's a fire. So the first thing that you always do are rescue. Make sure you're protecting the clients, okay? Get them away from the danger, get them someplace safe. Then alarm, activate the alarm, okay? If there's a phone right there, you can call and report the details, the location of the fire. Then confine or contain if you can safely do that. And I'm going to say this, don't ever put yourself at risk. You understand? Get your clients and you safely out, okay? But if you can contain the fire, so, if it's inside a room, you shut the door. Right? Make sure you turn off any oxygen and ventilate clients if they're on life support with a ambu bag. And we're going to talk more about what an ambu bag is. And if you safely can extinguish the fire, you can do it. But again, if you're going to put yourself in harm's way, don't do it. So make sure that you all know what RACE stands for and the order, right? Rescue, alarm, contain, extinguish. And then there's another acronym and it's called PASS. And that tells you how to use a fire extinguisher. Okay. And it's in sequence. P means pull the pin. A, aim the fire extinguisher at the base of the fire. And then S means squeeze the handle and then sweep. Sweep from side to side, covering the area of the fire. Okay. But again, don't do that unless you can safely do it. If the fire is big or out of control, get out. Make sure you know PASS. Okay. So there are different kinds of fire extinguishers, A, B, and C. So class A is for combustibles like paper, wood, fabric, upholstery, rags, those kinds of things, trash fires. B is for flammable liquids and gas fires. And C is for electrical fires. Why are there different classes? Well, for anybody that's ever had a fire in the kitchen, if you have a grease fire, for the love of God, don't pour water on it. Okay, because that's going to just make it worse. So, different types of strategies to address different types of fires. Okay, and it's also important to note fires need oxygen. So, if it's at all possible to either contain the fire or throw a blanket or something over it, like if it's a gas fire or a flammable liquid fire, like a grease fire, you can throw a heavy blanket over it, right, to contain it. Not water, not water. All right. And everybody knows stop, drop, and roll. If, heaven forbid, the fire touches you, to get the fire out, stop, drop, and roll on the ground to put the fire out so that you don't get burned. Okay. All right. Now let's talk about client falls. These are a big problem in hospitals, long-term care, you name it, all types of facilities. So older adults are usually the ones at increased risk because they have decreased strength, not always, but sometimes impaired mobility, impaired balance. Sometimes they have mobility aids like canes or walkers and they don't use them correctly. Sometimes it's unsafe clothing, right? In other words, maybe their pants are too long and they're, tripping on them. There can be environmental hazards, things that are in their path. There should never be, throw rugs or, extension cords that are running across somewhere where there's a risk of someone tripping over them, right? And also older adults sometimes have, limited endurance and sometimes they have visual or hearing problems, sensory perception that's decreased. So there's a whole list of reasons why older adults can be at risk, and also other clients, not just older adults, but people who have cognitive dysfunction. In other words, if they're confused or mentally ill, neurological problems, multiple sclerosis, cerebral palsy, those types of things. Lots of reasons why they can be at risk for falls. Okay, even adverse effects of medications that are sedating or cause people to become drowsy, puts them at risk. So, and to assess the risk, we have to understand that if a client has more than one risk factor, the more risk factors they have, the higher their risk for falls. Okay. So we don't want to fix it after it happens. We want to prevent it. So every client needs to be evaluated. And it's, of course, according to the healthcare facilities protocol. But I will tell you this, that healthcare facilities are really worried about falls because Medicare and Medicaid will not pay. They will not pay. If your client has been admitted and then they have additional injuries because they fell, that is called a no pay event. And, they don't like to not get paid. Okay. But more so than that, we don't want our clients to get hurt. It's sad that they had to make these no pay events in order to kind of make it clear that they needed to do something about it. Sad. Anyway, all right. So here is one example of a standardized fall risk assessment. This one's called the Morse Fall Scale Assessment. Okay. It's evidence-based and there are 6 areas of assessment. So you just, mark each one off and then it gives you a score. And at the end, it will give you a scoring guide. Okay. And what they're looking at is, do they have a history of falls? Do they have secondary diagnosis or diagnoses? Ambulatory aids, crutches, cane, walker, also furniture surfers or wall surfers. If they need a table to get up, that means they need assistance if they cannot independently get up, right? Do they have an IV? Do they have problems with their gait or with transferring from chair to bed or vice versa, right? And you can see the answers: impaired, weak, or normal. And what is their mental status? Are they completely A&O times 3, awake, alert, and oriented times 3, or are there some limitations, right? And so you would tally them up and come up with a score, and then they would give you score guidance to tell you, how high a risk the patient would be. Okay. So what do we do to prevent falls? Well, we do the risk assessment, but there are other things that we should be doing that are just as important. I'm going to make these a little bit bigger so that everyone can see them. Oh, too big. All right. So always complete a fall risk assessment, right? If you know that your client has orthostasis, orthostatic hypotension, which means that when they move, their blood pressure drops quickly. Now, blood pressure drops for everyone that moves, but to make it orthostatic hypotension or orthostasis, it would be a 20 millimeter of mercury drop in the systolic or a 10 millimeter of mercury drop in the diastolic. Okay. So if my blood pressure is 120 over 70 when I'm sitting, when I get up, it drops to 100 over 60. Bam, that's orthostasis, and I probably am dizzy. So that will put them at risk for falls. So you want to make sure that they sit on the side of the bed for a few seconds. And then when they do get up, they just stand there and let their blood pressure normalize. Okay. You want to make sure they know how to use their call light and answer the call light. Some facilities will use wristbands that are color coded to alert people, hey, that person's a fall risk. You know, we don't want anybody running to get to the toilet, so make sure that we are toileting them regularly, right? And make sure that the facility is adequately lit so that no one can say they can't see where they're going, okay? What else do? We want to orient the clients to their setting, right? To make sure that they know where's the call bell, where's their walker, right? Are there grab bars, right? Clients that are felt to be at risk or assessed to be at risk should be placed near the nurse's station. And I don't mean that we should take all their wheelchairs and sit them by the nurse's station all day. What I mean is their room should be near the nurse's station, okay? Hourly rounding is important. Minimally, nurses should be checking on their clients at least every hour. Make sure that their bedside table, or anything that they need, their telephone, their water, tissues, is right there and they can reach it. Make sure that their bed is always in the low position. So if you have just provided care and the bed is up, you want to make sure that you return the bed to the lowest position and lock the brakes so the bed's not moving. If a client is sedated or unconscious or otherwise compromised, they must have side rails. Now, we talked a little about this before, at least 2 side rails, because 4 of them constitutes what we talked about, and that's a restraint. But 2 side rails is not a restraint, and it's for safety if they are sedated or unconscious, okay? And again, never use full side rails for somebody who's mentally compromised because they're going to get confused and try to climb out. And I've seen someone break a femur doing that. Make sure they have something on their feet that's non-skid, and make sure that there's non-skid, items like a bath mat in the tub and the shower area so they're not going to fall. If their difficulty is with gait, use a gait belt. And I'm going to show everybody what a gait belt is. Make sure the floor is clean and dry and there's no clutter, nothing for them to trip over. And if they do use an assistive device, after you are sure that they use it safely, keep it right by their bed, right? And make sure if they wear glasses that their glasses are there, etc., so they can see where they're going. Seems pretty straightforward. And this is almost redundant. It's the same thing. Educate everybody about, the fall risks and how to prevent falls. Always lock wheels on beds, wheelchairs, and carts to prevent them from rolling. Some places use safety monitoring devices, like a chair alarm or a bed alarm. It has now been kind of argued that they are considered a restraint of sorts. So you have to go by your facility policy. If they are fall risk and they're confused, usually they will have a low bed and then they'll have a mat on the floor right next to the bed. So if they do climb out of bed, they're not going to fall onto a hard floor. They're going to fall onto a mat or another mattress. And anything that happens needs to be reported, because what we do is quality assurance and risk management are 2 nursing departments in every facility that look at incident reports, and they do what's called a root cause analysis. I'm not going to test you on this, not now, but later you'll need to know this. And they look to see, well, what happened and why do we think it happened? And even more important, what can we do so that it doesn't happen again? Right. That's the big reason for these incident reports, so we can gather the information and make sure it doesn't happen again. Okay. Now we'll move on to the next big thing, seizures. Okay. What is a seizure? A seizure is a sudden electrical surge in the brain. Some people have epilepsy, so that can cause them to have chronic seizures, but children can have febrile seizures, which are seizures related to high fevers. And then there are also some other medical problems that can cause seizures to happen. There are different types of seizures. If you've never seen one, they can be very disturbing, especially a tonic-clonic seizure. Used to be called a grand mal seizure. That is a violent, full-blown, generalized seizure where they will, tonic-clonic refers to the neuro effect on the muscles where they stiffen and then flex, stiffen and flex. If you've ever seen a fish out of water and it's kind of, thrashing all over the place, that's what a tonic-clonic seizure looks like in a person. Like I said, it can be disturbing. There are partial seizures, and that's where the electrical misfire in the brain is just in one part of it. Status epilepticus, that's a prolonged seizure. Anything over 5 minutes is dangerous because it can cause brain damage. So status epilepticus, a prolonged seizure greater than 5 minutes, is a medical emergency, okay? And then there's something called petit mal seizures, also known as absence seizures, mostly happen in kids, not so much adults, but they are a sudden blackout kind of a thing where you'll be talking to the person and then suddenly they'll just go blank for a few moments and then pick up right where they left off as if nothing happened. Right. So it's a brief, sudden lapse of consciousness, but they can look like they're still with you, eyes open and everything. Okay. Make sure you know the difference between a tonic-clonic, partial, and absence seizure. Okay. Now we're going to talk about what happens before, during, and after. And know these words. Okay. There's something called an aura. They also call it a prodrome, but aura is the most common term. It's like a sensation that happens right before a seizure starts. So for people that have chronic seizures, they will either smell something or they'll hear something or they'll even feel something. It's almost like a warning that their body's giving them, you're going to have a seizure. And it sometimes gives them the opportunity to get themselves into a safe place. Okay. Some people smell something like they smell toast, right? No one can explain that, but it's a subjective sensation or emotion like a smell or a sound or a color. They can even feel nauseous, or it can even be an emotional thing. Like all of a sudden they have this wave of sadness, but that's their warning. And people that have chronic seizures get to know their own aura. Ictal is the actual seizure. Okay. That's when the electrical activity in the brain is going haywire and they are actually seizing. Post-ictal is after the seizure. And that can last from minutes, even to days for some people, but on average, it lasts up to about 30 minutes. The person has their eyes open typically, but they're snoring. It looks like they're sleeping. When they do regain awareness of where they are, they're going to feel confused, exhausted, probably sore with a tonic-clonic seizure, and they typically have no memory of the seizure. So in their mind, they just blacked out. Okay. So what do we do if we have a patient that's on seizure precautions? And what do we do if they do have a seizure? Okay. First of all, make sure, and you need to know these are test questions from the board. If the patient's on seizure precautions, always have rescue equipment at the bedside. That means they should have oxygen, some type of an oral airway, suction equipment, and padding for the side rails. Clients that are at a high risk for tonic-clonic seizures should have some type of IV access, a saline lock or a HEP lock, in case we need to get IV meds in them to stop a seizure. The medication, I'm going to actually put this in here. The medication of choice, medication to stop a seizure is diazepam. Okay, that is a benzo, that's Valium, and it's got to be IV. Okay, I know that there are some facilities that have rectal diazepam, but just to keep the record straight, IV is what we use in hospitals. IV diazepam, bam, it's going to stop the seizure. Okay. Make sure that if that client's on seizure precautions, that we're checking their environment, that there's nothing in there that could pose a risk for them to be injured if they do have a seizure. Okay. If they are in bed and they start to seize, get them out of the bed and onto the floor because otherwise they're going to fall out of the bed. So as gently as possible, get them out of the bed onto the floor. The first thing is protect their head because their head will be thrashing. Okay. Get a pillow under their head, a rolled up towel, a jacket, a shirt, a blanket, anything under their head. If they have anything that's restrictive as far as clothing, like a necktie, loosen it. Do not restrain the patient in any way. Do not put anything in their mouth. I know there's an old wives' tale that they're going to swallow their tongue. You can't swallow your tongue. Okay. It's not possible. Okay. So get them on the floor, protect their head, loosen restrictive clothing, and just start timing the seizure. That's it. Okay, that's it. Don't try to get on them and restrain them. Don't touch them. Okay, just keep their head safe so that they don't have a brain injury. Okay. After the seizure's over, assess them, determine their mental status, get a pulse ox, vital signs, tell them what happened, and you want a quiet environment for them to kind of recover. And then you're going to document what happened. So precipitating behavior, in other words, what happened before the seizure, and then tell me what happened during the seizure, right? You're going to write all of that down. That's going to be documented, and you will be calling the healthcare provider, the doctor or the nurse practitioner. All right, so make sure you understand all of this about seizures. All right, on to a fun subject, restraints and seclusion. Sometimes you'll have a client that, for various reasons, usually mental illness, and to protect themselves or other clients or staff, they may require seclusion or restraints. Okay. Generally speaking, this is the last resort. Okay. This is the last resort. In other words, you should have tried every other potential intervention and documented that before you restrain or seclude somebody. Okay. I'm going to get rid of this one. Don't worry about this sentence right here because typically clients don't request seclusion. I mean, that's very rare. And what is a restraint? Anything that is either physical, in other words, it restricts their movement, a vest, a belt, mittens, right? Limb restraints, like wrist restraints. The lap, they call it a lap buddy. It's still a belt. Full bed rails. Those are all physical restraints that restrict movement. Chemical restraints are when we use medications like sedatives or neuroleptics or psychotropic meds, psych meds, not because the client needs them, but to sedate the client and calm them down. Okay. And a chemical restraint requires the same types of nursing interventions as a physical restraint. It's got to be the last resort. You tried everything else and they're putting themselves at risk. They're going to hurt themselves. They're going to hurt another resident or client, or they're going to hurt you or other staff members. Okay. Restraints can cause complications, right? They really can. So it is never appropriate to use seclusion or restraint for convenience, for punishment, for clients who are physical or mentally unstable, but not a danger, right? They're not going to hurt themselves. They're jogging in place. Maybe it's annoying, but they're not going to hurt you, right? And then clients who can't tolerate the decreased stimulation of a seclusion room. There are instances where seclusion can actually escalate the situation rather than de-escalate it. It's a form of torture during times of war. Seclusion, even in jails, they can put you in solitary. We are social creatures and we need to be around other people. So seclusion is really, when you put a client into a room alone and isolate them, it can make a situation worse. I'm not a big fan of seclusion. I'm not a big fan of restraints either, but So again, like I said, when everything else you've done has failed, and now this client is somehow in danger to either hurting himself or others, okay? Then here's what you have to do before you can use a seclusion or a restraint. So the doctor or nurse practitioner or PA has to write an order for it after face-to-face assessing the client. Can't be over the phone. They have to be there and examine the client. And that prescription has to include why they're being restrained, what type of restraints, where they're putting the restraints, how long you're going to use the restraints, and what was the behavior that justified the restraint. Okay. Prescriptions are good for 24 hours. And for adults, you can only restrain somebody for 4 hours at a time. Okay. Don't worry about the child. The numbers are there, but we're not going to test you on that. You can't have a PRN prescription for a restraint. Can't be as needed. Okay. As the nurse, you're going to be doing circ checks, neurovascular checks every 15 minutes. You heard me. And documenting. And the restraints must be released every 2 hours. An example would be if somebody has wrist restraints, you would go in and release one of them, let their hand, let them move around, then put that one back on and then release the other one. And neurovascular checks mean whatever type of restraint they have, distal to the restraint, is that restraint doing anything to impinge blood flow or nervous activity? So in other words, if they have wrist restraints, you're checking the pulse, radial pulse, you're checking cap refill in their hands, you're making sure their hands are warm, etc. Okay? And documenting such. Okay? You should always pad any bony prominences so that there's no skin breakdown. You always need to use a quick release knot. Okay, so this way when you pull it, it releases. And if you're tying the restraints to the bed frame, never tie the restraint to a movable part of the bed. So if you tie the restraint to the bed rail that goes up and down, that client's going to get hurt. Okay. You always make sure the restraints are loose enough for range of motion and there's enough room to fit 2 fingers, 2 finger breaths between the restraint and the client. Make sure they have food and fluid. Make sure that they have a way to maintain hygiene and elimination. In other words, they have to poo or pee. Monitor their vital signs. And you have to offer range of motion exercises for their extremities if their extremities are, restrained. Like I said, you have to write the precipitating events. What was the client doing? What else did you try to fix the situation and failed? When did you put the restraints on? And when did you remove them? What kind of restraints? What did the client do while they were restrained? And then what did you do while they were restrained? Did you do range of motion, neuro checks, right? Did you remove them? Like I said, every 2 hours, skin checks. What is the condition of the body part that's restrained? When you did take the restraints off, how did the client respond? Did you administer any medications while they were restrained? And also, never leave a client alone while restrained. Okay, I've seen some terrible things happen. So there should always be eyes on the client. Okay, so that's what you need to know about fire safety and fall safety and restraints, okay, and seizures. Any questions? Look, I'm dropping the mic. All right, that is the end of this. I am going to stop recording and I will see you next time.